On closer inspection, usually closer inspection, all the orthopedic is the same one. Closer SWAD, swelling, scar, sinus, skin changes, wasting, attitude, and deformity. SWAD, swelling, scar, sinus, skin changes, wasting, attitude, and deformity. Just mention, just go through. There's no swelling, there's no scar, there's no sinus, skin changes. Alright. And after that, feel. And then compare both sides. There's no increase in warmth compared to the contralateral shoulder. Ada sakit kat mana-mana? Tak ada, saya akan tekan sikit. Kalau ada sakit, bagi tahu saya. So go slowly. From the sternoclavicular joint, along the clavicle, up to the acromyoclavicular joint, to the coracoid process, to the acromyon, go according to the spine of scapula. Then, here you need to palpate two things, very important. The GT, because your rotator cuff tendon is attached here. You've got supraspinatus tendinitis and all that, it will be painful here, or any cuff tear. Okay? So you palpate the GT, any pain or not. Then after that, you rotate the hand a bit, palpate the front. What am I palpating? Bicipital growth for any bicipital tendinitis. Okay, that's how you do palpation for shoulder. Okay, alright. Now, move. Alright, so move. Just ikut arahan saya, ikut saya punya movement. Dua-dua tangan letak macam ni. So, palm facing forward. That's your normal attitude. And then slowly go up as much as possible sampai you boleh dapat. Alright, so most of the time, if it is a true patient, not a fake patient, usually until about 90 degrees only. They won't be able to go beyond that. Then at this point of time, you need to ask them, tak boleh naik sebab sakit atau rasa ketat? Then after that, you can say, there's an active abduction from 0 to 90 degrees, limited by pain or limited by stiffness. Sometimes can be both, limited by pain and stiffness. Alright, then you do passive. Okay, saya akan tolong naik sikit. Kalau terlalu sakit, bagi tahu saya. Ada, boleh tahan ah. Okay, then you comment. With the passive abduction, it can improve to up to how many degrees? Okay, now, as you do the abduction for the patient, there are two other things you need to look for. Alright, so as you go up, alright, so 60 to 120 degrees is your painful up. So you want to see, is there any painful up or not? So if it is painful from here to here, but after that, okay, what does that mean? Impingement. Patient is having impingement syndrome. Alright, now if the patient can go all the way up already, now after that you need to ask them to slowly put it down. What are you trying to see? Drop arm sign. If there is a drop arm sign, what does that mean? Supraspinatus muscle tear or tendon tear. Supraspinatus tendon tear. Alright, so if tear cannot maintain the drop. So again, you ask them to do abduction. Macam saya, dua-dua kat tepi, naik sampai atas. Alright, then cannot, limited by pain or limited by stiffness. Saya akan tolong sikit, improve or doesn't improve. Alright, and after that, any painful up or not, you comment. Then slowly, okay, slowly put it down. Cannot. Drop arm side, positive or negative. Okay, understand? Right. Then after that, usually we don't do adduction. Adduction, we don't do. Alright, forward flexion. Alright, so forward flexion, ask the patient to do like this, go all the way up. Up to, all the way up, 180 degrees. Then after that, go extend behind. Extension usually about 0 to 45 degrees. Straight away, to make it smooth, ask them to go up. This is called composite internal rotation. Composite internal rotation, this movement. Alright, so patient with shoulder pathology, very limited, so they'll be having difficulty with their bra for elderly female. Alright, so usually you should be able to, your tip of the thumb should be between T4 to T8, but you just report as it is. Alright, for example, on the patient's right shoulder composite internal rotation, the tip of the thumb is located around the lumbosacral region, just behind the sacrum or at the thoracolumbar region. Just report as it is. No need to be so exact one, just roughly. After that, compare to the other side. Okay? Then after that, the only movement that you haven't checked yet at this moment is external rotation. Right? Just now, abduction, I say no need to check. Forward flexion, extension, internal rotation. Now, external rotation. So, you need to ask the patient to tell them, elbow ni jangan gerak langsung, stay kat sana saja. If not, they don't follow order, then your examination go haywire already. Okay? Tapi buka seberapa yang boleh. Okay, so active external rotation. If they cannot, then after that you help a little bit lah. Okay, alright. So then look, few move done already. Alright, then after that you go for all your special tests for your shoulder. Usually, I'll straight away continue with the strength of my rotator cuff tendon in both young patient and old patient. Alright, I'll do this for first, and only then I will cabang, because usually young patient they will have shoulder instability. So it's a different set of tests. For elderly, painful shoulder is a different set of tests. Okay, why I tell you I usually check this rotator muscle strength after the ROM is because it makes it more smooth. You see, just now you're checking external rotation. You straight away continue with the strength of your infraspinatus. How you check? You maximally externally rotate, okay, and then after that ask the patient to maintain. If they cannot, if once you release your hand, they cannot maintain, it go into like this. This is called external rotation leg sign positive. ER leg sign. External rotation leg sign positive. They cannot maintain your maximum external rotation. And that is indicating your infraspinatus weakness. Okay? Okay. So after that, you check your teres minor weakness. What is a sign that is used to tell teres minor weakness? Anybody? Yes, Hornblower sign. Alright, so Hornblower sign, what you do is that you ask the patient to do 90-90, see whether they can do or not. But I can tell you, if it's a real patient, they won't be able to do one, because they got a so painful shoulder already. You want to ask them 90-90 some more, not going to be possible. Alright, so the modified way is that you ask them to put their hand into their mouth. So for Malay saya, macam mana you makan. Okay, and they won't be able to do this. So what do? Yes, they'll do this. Bring your hand to the mouth. Macam mana you bring your hand to your mouth? They'll do this. Because this movement will require external rotation. You see? You eat like this. You can actually externally rotate your humerus. This movement is possible because your teres minor is working. When their teres minor is not working, you go like this. So that's how they blow the horn. Hornblower sign. Understand now? Okay? They won't be able to do 90-90 like this. So ask them to bring the hand to the mouth. This requires external rotation in order to produce this movement. When they cannot, they do like this. This is hornblower sign, blowing the horn. Alright. Then after that, you check your infraspinatus ready, teres minor ready. You check your supraspinatus. How do you check your supraspinatus strength? Yes, Jobe test. Alright. So Jobe test like this. Okay. So you see, Jobe test. A lot of people will do this kind of mistake. The angle all different and incorrect. It should be here, here. Alright. Now your spine of the scapula, your scapula is facing about 30 degrees anteriorly. Alright. So from here, 30 degrees. Why? Because this is your plane of your scapula. Your supraspinatus muscle is located here. So you want to generate the highest tension along with the muscle fibers orientation. Alright. So that's why you go in this degree, 30 degrees. Alright. Now what is the function of supraspinatus?
Initiate abduction.
Initiate abduction, isn't it? So initiate should be somewhere here, about 15 to 30 degrees of abduction. Alright. So ask the patient to do this 30 degrees, and then here is about 15 to 30 degrees, just like. Then you push it down. See the strength, strong or not. Alright. So that's how you check your supraspinatus. Now, the last rotator cuff muscle that we haven't checked yet is which one? Subscapularis. Subscapularis, there are many tests, alright? First of all, it can be divided into upper subscapularis and lower subscapularis. Okay. Now, what is this test called? Gerber lift-off test, right? Gerber lift-off test. You ask them to push against your hand, alright? This is to check the lower subscap. Then after that, what is this test called?
Napoleon.
Napoleon belly press test. You ask them to press, and then after that, this one has got to be here. Okay, but I'll tell you what I usually do. All right, this is to check which one, upper or lower subscap.
Supra.
Upper subscap. Napoleon belly press test is to check the upper subscap. Gerber lift off is to check the lower subscap. But I can tell you, most of the time, not most of the time, all the time, I use bear hug test. Heard before? Bear hug test? Yes. Okay, right. So it's like this. Like this, and then after that, tahan. Kuat. This is bear hug test. This is to check, you get internal rotation, subscapularis. Why I don't check Gerber lift off test and Napoleon belly press test? If you notice, you ask your patient to do, they cannot really comprehend the instructions, right? You see, you ask them to do Gerber lift off test. Supposedly, it should be like this. They'll do like this, right? And they don't know what to do. Then after that, you're stuck there. No, bukan, macam ni. Then you're lost. Alright. This one also, a lot of times, they don't know where to place their elbow. They try because they got a pain, they got a pathology, and then after that, they try to compensate and all that. Then after that, you lose your interpretation of the test. So all the time, I do bear hug test. Just as simple. Check the strength only. Alright. So you check all your 4 rotator cuff muscle already. Only then you go for your special test. Alright. Now, I'm gonna go through with you the elderly shoulder. Okay, elderly shoulder. So usually, ACJ arthritis, impingement syndrome, bicipital tendinitis. Alright. Then your glenohumeral joint arthritis and AV end of the shoulder usually would have already been detected earlier on because of the severe loss of movement in all directions. Arthritis is in all directions. Right? Alright. Impingement syndrome. What is this test called? Hawkin test. Alright. So abduction. Then after that, you passively internally rotate, bring in different direction. With this, you're actually bringing the patient's GT just underneath the acromion. So it's grinding that. If you've got a supraspinatus tendinitis or what we call impingement syndrome, it will be very painful. Very important to ask your patient where is the pain when the patient complains of pain. If do this already but the pain is here, then it's considered negative. It has got to be here at the acromion there. So that's Hawkin test. Second test I will do for my impingement is Neer sign. You need to be able to know the difference between Neer sign and Neer test. Okay? Neer sign, forearm pronated. Forearm pronated. From here, you passively bring the patient's shoulder up. Usually up to about 90, 100 degrees, they will have pain at the acromion here. Alright? This Neer sign positive. This impingement syndrome. Alright? Now, once you inject your subacromial injection, and then after that, there's further improvement of your forward flexion. This is called Neer's test. Alright? So, I always remember with Neer sign is S, Neer test is T, right? S comes before T, right? So, you do this one, Neer sign first, and after that, no improvement, you inject, then after that, you do your Neer's test. But of course, in your exam, definitely you are not going to perform Neer's test. We're going to injection for you to inject and all that. Right? Alright, so just Neer sign and Hawkin test for impingement. Next, ACJ arthritis. Anybody know how to check? Yes, scarf test. Alright, so here, put here, and then here, stabilize the shoulder at the back. Here you push. When you are doing this, you're actually compressing your ACJ. Understand? So they got a pain, not anywhere else, but at the ACJ. Right, this is called scarf test. Alright, scarf test positive, indicative of ACJ arthritis. Next, we do bicipital tendinitis. Alright, so what are the 2 tests for bicipital tendinitis? Speed and Yergason. Very good. So bicipital tendinitis, speed test, do like this. Elbow extension. Don't let me push it down. And patient complain of pain. Again, not anywhere else, but bicipital groove. Just consider speed test positive. Now, second case is a Yergason. So elbow flexion, grabs the patient's hand, and then after that, biceps do what besides elbow flexion? Supination. So you need to ask the patient supinate against resistance. Saya akan tutup you dengan tangan, you kena buka, jangan bagi. Okay, this is supinate against resistance. And again, patient feel pain. over the bicipital groove. At this point of time, you would have roughly completed your elderly shoulder examination. Alright, then you need to rule out other possible pathology. Do you guys have short case? No short case, just long case only lah. Alright, then I think you need to do screening. When I talk about screening, it's just gentle palpation and also a quick range of motion. For example, because you know that your differential diagnosis is going to put referred pin from the neck or cervical radiculopathy, then when the patient has got the shoulder pain, that's your differential diagnosis. So when you want to screen for the neck, just do like this. Sini ada sakit tak? Tak ada, saya tekan sikit. Ini semua tak ada sakit lah. Okay, boleh tengok ke bawah, tengok ke atas, ke tepi, sini. Okay, telinga kanan, bahu kanan, telinga kiri, bahu kiri. That's all. Screening for cervical, done. No need to do a thorough one. At least you just tell the examiner, yeah, I screened for the cervical, but of course I would like to end the examination by a thorough cervical spine examination. But so far from what I checked, the range of motion is full in all directions and there's absence of tenderness at the midline cervical spine. That's how you do screening. For example, when you do knee examination, you want to screen for the hip, also you do the same thing. Just ROM of the hip and palpate around the hip joint. That's all. That's the screening. Okay, shoulder, so far okay. Now, instability. Alright, instability of the shoulder can be divided into anterior, posterior, and inferior instability. Okay, so anterior instability, you do your anterior shoulder apprehension test. 90, 90, stabilize, scapula, push it backwards. Because when you push it backwards along the elbow here, you're bringing your humeral head anteriorly. Look at the patient's face. Apprehension sign. Alright, these are shoulder apprehension sign. Alright, now if now dislocate that, okay, just put it back. Alright, and then after that, anterior, the other one we do is an anterior drawer test. Stabilize the scapula. Use your this one. Grabs the humeral neck here and then translate it. See how much you can go, just like your drawer test. Anterior drawer test, go front, go towards the back. Anterior drawer, posterior drawer. Okay, then after that, you see if there's any sulcus sign. Have you seen sulcus sign before? There'll be a deep groove in between your lateral edge of your acromyon and also your humeral head, because the shoulder has already subluxated inferiorly. So that's why you have this sulcus sign. Alright, so those are the tests for instability. Are they going to come for your exam? I'm not sure. If they have, maybe instability. But elderly shoulder is quite a common case. Elderly shoulder. Okay, alright, thank you.
Doctor, what about frozen shoulder?
Okay.
Is there a specific test for that?
No, frozen shoulder, there's no specific test, but from all your standard physical examination, you will be able to pick up how frozen shoulder, the first movement it will be affected is what? External rotation. The first to be affected is external rotation because of your coracohumeral ligament. Because it affects your coracohumeral ligament, so you can't go external rotation. So once you see the patients can externally rotate quite well, you know it's definitely not frozen shoulder already. Definitely not frozen shoulder. Alright. Now usually frozen shoulder will have a reduce in the range of motion in all directions, particularly external rotation, combined with joint line tenderness. The rest, tak berapa lah. So that's how you put a frozen shoulder. But frozen shoulder, always don't put it as your first few differential because it's the diagnosis of exclusion. So always put it last. When you have a global reduction of ROM, joint line tenderness, then you can put frozen shoulder. Okay? Alright, thank you. Right. Now, any questions so far before we go for the provisional differential diagnosis of shoulder? Yes?
I'm not quite sure about the Yergason test.
Okay. Okay, now you come here, I do on you. Or you do on me, then you'll remember. Just get it all clear, alright? Okay, so now you're going to check on my left, alright, Yergason test. Because biceps function is to supinate, alright? So, now you grab my hand here, and then after that you say, sekarang saya akan tutup you punya tangan.
Okay.
Alright, tutup. And then jangan bagi saya tutup.
But tutup is pronation, right?
Nah, usually they say tutup is like this, and then buka is like this. Tutup is pronation. Alright. So you are gonna close my hand.
Okay.
I need to buka.
It's like kind of pull.
Yes.
Pull
Yeah.
away,
So I need to supinate against resistance.
Okay.
the clinician is going to, the candidate is going to, what do you call? The patient is going to supinate. And then you don't let me supinate.
Oh, okay. Okay.
You got a pain at the back. Okay. Okay, any questions so far? Just ask Odin. Just clarify. Okay, if no, then we talk about the how to summarize your findings. All right. So from my physical examination, the relevant positive findings include a global reduction of the patient's right shoulder range of motion associated with features of impingement syndrome and bicipital tendinitis, as evidenced by positive Hawkin's Kennedy's test and Neer's sign, and also positive speed test and Yergason test. Something like that, depending on your findings. So that is the way to summarize your physical examination findings. Sweet and simple. With features of what and what as evidenced by what and what. That's all. Or with features of ACJ arthritis as evidenced by a positive scuff test. Okay. Right. So provisional diagnosis, you divide them into two big groups. One is a main complaint is a loss of ROM in all directions. The other one is painful shoulder, just pain only, but the ROM is still quite okay. All right. So when you have a reduce in the range of motion in all directions, sometimes can have crepitals and all that. What comes to your mind? Just mention. Osteoarthritis. Osteoarthritis of the shoulder joint, okay, can be your provisional or differential. The other one, AVN of the humeral head, avascular necrosis, it flattened out already. So then after that, frozen shoulder, yeah, will be one of it. Of course, when the patient has got a rotator cuff deficiency, they can go into rotator cuff arthropathy. But usually you don't put that as your provisional and differential until you see the X-ray. Only then, usually it's like a radiological diagnosis like that, rotator cuff arthropathy. So those are your, if a loss of ROM, these are your provisional and differential diagnosis. If it is a painful shoulder, usually it's like a package one. Painful shoulder, you will have pain here, and after that, there will be a painful arc, and after that, your Neer sign will be positive, Hawkin Kennedy will be positive. So in such kind of case, your provisional and differential should include impingement syndrome, bicipital tendinitis, ACJ arthritis, all right, referred pain from the cervical spine. Okay, I think that's all. All right. For those pain, all those that could be painful around this area, impingement syndrome, bicipital tendinitis, and then after that, ACJ arthritis, referred pain from the cervical spine. All right, now imaging. What kind of imaging do you want to do for this kind of elderly painful shoulder? And we go like this, one round. I will order radiograph in what view? Okay, so usually we order AP and supraspinatus outlet view. Heard before supraspinatus outlet view? Okay, go back and Google the image. Basically, that is to help you to see the morphology of your acromion. According to this Bigliani, it can be divided into flat, curve, and hook. So if you look at the lateral aspect, this is like your acromion like that. The supraspinatus tendon go like that. Alright? So flat is okay. Curve maybe can irritate your supraspinatus tendon. When it's hook, that it will irritate your supraspinatus tendon. Flat, curve, and hook. That is a Bigliani classification for your acromion. And that is only possible when you do the supraspinatus outlet view. You can see that. Alright. Otherwise, in the AP view, you want to look at features of osteoarthritis. What are the 4 features of osteoarthritis you want to look for? Okay. Subchondrosis, subchondral sclerosis, LOSS, right? Loss of joint space, osteophyte. So you just mentioned, because it's in your provisional and differential diagnosis. So in the shoulder AP view, I want to look for the features of a loss of joint space, osteophyte formation, subchondrosis, and subchondral sclerosis. Alright. So, right, the next investigation always remember is ultrasound, not MRI. You only do MRI of the shoulder when you're going for surgery. Okay? And there are only two kind of cases when you want to go for surgery. One is acute traumatic tear. Why? Because it's an acute traumatic tear, the healing will be better if you do early surgery. So you want to go in and see whether there's any other associated pathology that you can prepare your instruments and all that so that you can tackle in the same setting. Number two, after failure of conservative treatment. Alright, then you want to go in for surgery, then you do an MRI. So don't ever mention MRI as the investigation after X-ray. Mention ultrasound first. And the next question you could have already expected. Why ultrasound? Right. Now, then you mention the standard answer for that. Advantages of ultrasound include it is cheap, it is easily available, it can be done at the bedside, and it allows dynamic assessment. Why dynamic assessment? Because you just place your ultrasound probe and ask the patient to move, and after that you want to see the gliding and all that. So there's a dynamic assessment. Those are the advantages of ultrasound. But ultrasound is not without its disadvantages. What do you guys think? What are the disadvantages of ultrasound? Very good. Operator dependent, that's number one. Number two, it cannot be used to evaluate intra-articular pathology. For example, if you've got a labral tear and all that, you won't be able to see. But you will be able to see all your rotator cuff, tendon tear and all that. And in fact, it has got similar sensitivity, specificity and accuracy compared to MRI in detecting rotator cuff tear. Okay, so ultrasound should be your next in line. Alright, only when the patient needs surgery, you do an MRI of the shoulder without contrast. You can do an MRA lah, MR arthrogram. But you do an MRI of the right shoulder. I think that's a good enough answer. Alright, so management. Conservative and surgical. Conservative same lah. Rest, activity modification, physiotherapy, range of motion, exercise, rotator cuff muscle strengthening, periscapular muscle strengthening, give some analgesia, and then NSAIDs, cap Celebrex 200 mg BD, yeah, those kind of stuff lah. Alright. Then after that, if all this fail, then you can also give subacromial injection. We give steroids. What do we give? 40 mg of triamcinolone. That is a steroids. 40 mg of triamcinolone is equivalent to 1 ml. 1 ml of that plus 1 ml of lignocaine. Alright, so these 2 ml we inject into the subacromial area. Usually it's here, from behind here. 2 cm inferior and medial to your lateral edge of your acromion. You poke it, aim towards your coracoid process. That's a subacromial injection. Alright, so if not, then you do surgery. Alright, surgery very much depends on your pathology. For example, if it is a rotator cuff tear, you do a repair or you do a debridement. Alright. If it is a bicipital tendinitis, you can do either two only, tenotomy or tenodesis. Alright. If ACJ arthritis, you can resect the lateral 1 to 1.5 cm of your clavicle. Okay. If you got ACJ arthritis. Now, if you got a glenohumeral joint arthritis, then you replace the shoulder. Okay. Alright. Any question? So conservative and surgical. Surgery very much depends on your pathology. Bicipital tendinitis, tenotomy or tenodesis. ACJ arthritis, you resect the lateral 1 to 1.5 cm of your clavicle. It is also called a Mumford procedure. Alright, now if it is a impingement syndrome, supraspinatus tendinitis, alright, so what you can do is arthroscopic acromyoplasty or subacromial decompression. Basically, you put in the scope, and then because just now I said, right, flat curve and hook, right, then they can have osteophytes there. Just remove all the osteophytes so that it doesn't irritate your supraspinatus tendon. This is called acromyoplasty or subacromial decompression.